managed commercial contracts for an information technology consulting firm in Virginia and Maryland. Dr. Hartsfield was a community affairs professional in the nonprofit field in New York for more than 25 years, where she as a leader in nonprofit organizations. She graduated with honors from Lincoln University of Technology. So I could ask you guys to come together to welcome Regina.
Well, thank you so much, and good evening, everyone. Good evening. It is an honor to be here and to see this whole full of issues for Thank you again. I am honored to and a wonderful and our efforts include a focus on adding research, public and professional health education. We represent a membership of 57 community-based nonprofit fighting and caring for they are trusted resources and is a growing issue for others. The lack of access to services, facilities, coverage, funding, or even information deeply affects the ability of individuals to make informed decisions regarding the impact of sickle cell. The topic is no longer a topic just among caregivers or individually addressed. The topic is a conversation I've had with sickle cell organizations, pharmaceutical federal institutions, support and or provide coverage for reproductive health in people children institutions. Because of the collective efforts of those on the panel and all of understand that or have or lack of medication they are held accountable for decisions about the reproductive future of their young daughter who is about to undergo hormonal transformation. A number of life-altering therapies, including bone marrow transplant, gene therapies. I can speak louder. Okay, is that better? All right. As I was saying, here's what we know. A number of life-altering therapies, including bone marrow transplants and two approved gene therapies for sickle cell disease, can cause individuals to become infertile. And yet, very few insurers cover fertility preservation. Without insurance, the out-of-pocket costs are unobtainable for most Americans. There is legislation in Congress, the Access to Infertility Treatment Care Act, which is led by Representative Rosa DeLauro and Senator Cory Booker. This legislation would require most private health insurance plans, as well as plans offered by Medicaid and other public insurers, to provide coverage for fertility preservation services for individuals who undergo medically necessary procedures that may cause infertility, such as chemotherapy. As we know, chemotherapy is used in both bone marrow transplantation and SCD gene therapy. But unfortunately, few politicians want to engage in any issue related to reproductive health. The bill just mentioned is not bipartisan and is unlikely to advance in this Congress. Pharmaceutical companies are also seeking ways by which they could pay for the cost of fertility preservation for individuals who wish to pursue gene therapy. One gene therapy manufacturer has sued the U.S. government for permission to pay for fertility treatment for people who undergo gene therapy. Current law prohibits pharmaceutical companies from paying for things like travel, lodging, fertility preservation for individuals insured by Medicare and Medicaid because it is seen as inducing patients to choose that particular drug, which is federally reimbursed. However, manufacturers are able to cover those costs for individuals with private insurance. Travel, lodging, and fertility preservation are key components of cellular and gene therapy treatments and cannot be excluded from the Medicare and Medicaid conversation. So what I want you to know is progress is being made. For example, under the Center for Medicare and Medicaid Innovations Cell and Gene Therapy Access Model, participating manufacturers will be required to provide payment for certain fertility preservation services for individuals who receive a gene therapy as part of the model. This model could begin in certain states as early as January 2025, and it aims to improve access to sickle cell disease gene therapy for individuals insured by Medicare. I also want you to know SCDA will continue to advocate for reproductive health care and fertility preservation. We will continue to encourage policy changes that reflect the needs of the sickle cell community in this historic era of treatment options. Working with SC-RED and others in the reproductive health care space, SCDAA will continue to amplify your voice, your needs, your concerns on this critical issue until there is parity between sickle cell disease reproductive health care services and the reproductive health care services that currently exist and are made available to patients being treated for other diseases. It is my pleasure to introduce Dr. Wanda Sherman. Dr. Sherney is the CEO and Medical Director of the Sickle Cell Disease Association of America, Michigan chapter. She is a proud graduate of the Detroit Public Schools and a proud graduate of Howard University Medical School. Dr. Whitney Sherney has spent 30 years growing this clinic started by her father, Dr. Charles Whitney, who is also the founder of SCDMA. So we've come to this. Please welcome Dr. Wanda. Okay, good evening. I am absolutely thrilled to be here. I met so many interesting and exciting people in the reception. I wish it had been longer, but maybe we'll have some time afterwards. There are a lot of people in this room that know a lot more about sickle cell disease than me, okay? But there might be a few people in the room that don't know much about sickle cell disease at all. So just to level set, it's very simple, like 3 sentences, okay? It's a blood disease, okay? It is not a black disease, it's a blood disease, okay? And what happens is those red blood cells, they take on that unusual shape, shaped like a farmer's sickle. You know, the kids say we should call it banana cell disease, okay? But what's a sickle, right? And so what happens is these red blood cells are sticky and they're fragile. And the fact that they're sticky causes blood vessels, right? When they block blood vessels, that causes pain. The hallmark of sickle cell disease is pain. If you don't know anything about sickle cell, isn't that painful? That's what people will say to me, right? But the other thing is that when the blood vessels get blocked, you can't get oxygen to your vital organs, okay? And the vital organs that we're going to focus on today are the reproductive organs, okay? But it affects every part of the body, okay? Now, the other thing is that the red blood cells are fragile, so they break down early, and that's what causes the anemia, okay? And that's what causes the fatigue. And as a pediatrician, I really focus on pain. But as I watch boys grow, and they would just talk about the fatigue, like I slept for 12 hours, I need 12 more hours to sleep. So that is 30 seconds or 90 seconds to the 701, okay? And now, okay, this one cut. So I have the distinct honor bio. I'm not looking at a CV. I'm going to tell you some personal stuff. I said, I'm going to tell you, okay? Because okay, so Tiana, which is Dale, you remember, when I was a panel person, the moderator for a panel for curative therapy at the NIH, to cure sickle cell disease in 5 years. That's what they told me at Howard in 1983. Okay, I'm still with it. Okay, and so now we have all these panelists and they're answering all these questions, and it's really a wonderful panel. And then we call for questions. And some woman stands up in the background and says, "I have a question." I'm like, "Who are you?" Right? And I said, "What is your question?" And she said, "How come you always talk about the successes and you don't talk about the failures?" Right? And she talked about failing a bone marrow transplant, and which triggered her with fertility issues. Right? She went to find out what are the resources available for fertility preservation, and she found all kinds of grants for cancer, but none for sickle cell. So what did she do? Oh my God, she started a national, becoming international organization. I mean, we have a new I mean, we have been ever since. Okay, and I feel like I'm a part of her family, and her family is here. And I just want you to wave so everybody knows that that's her mom. And, the last thing I'm going to say is that when we had our walk last year, um, Tiana had a table at Serena, excited about that. And I behind her. And what it said was, to the Kim Smith Whitley of Warriors, right? Because if you're the Kim Smith Whitley of anything, right, then you are the bomb. So I want to bring a woman to the bomb, right? And she's remarkable, and you love her, and come on, Tiana.
so full. I remember telling you, John, I had this reoccurring dream that I got here and nobody showed up. So thank you for proving me wrong. I think every seat is full. So I just cannot, like, words cannot express how much it means that you are here with me on a Friday night, kicking off Sickle Cell Awareness Month to have this critical conversation. There are so many people in the room that have just poured into me over the years and not just care about my organization, but care about me. And I just cannot thank you enough. I want to recognize my board. My board members are here. My medical advisors are here. Guys, just like wave your hand. We have a strategic planning meeting tomorrow, so I'm going to work them. So let's have fun tonight. But yeah, so we're going to have this amazing panel discussion, do some remarks, and then we're going to eat dinner and just enjoy yourselves. So thank you again for coming. I'm like a little nervous, and I was also trying to be cute, so I didn't wear my glasses. So, you know why.
You can't take her anywhere. So here, I'm glad we're not going to be so serious, okay? We're talking about a serious issue, okay? We're going to kind of lighten it up a little bit, okay? That'll be good. And so part of it is going to be, I don't know how many of you recognize these people here, but I'm going to guarantee you that their resumes are fantastic, okay? And their bios are wonderful. But I'm more interested in what they have to say, okay? And so what I'd like to do is have each of you introduce yourselves. Let us know what you'd like us to know about you, okay? And then hammer you with all those questions, okay? And because Lydia, Dr. Becker, I went back and forth, what am I going to do, okay? You're going to be first to get the questions, okay? So you're going to be first to introduce yourself. How about that? Does that work? Okay. Does this work? Does your mic work? This works.
Good evening, my name is Lydia. I'm a native of Brooklyn. Can you hear her? That's my best line. My name is Lydia Becker. I'm the interim director of the Sickle Cell Center for Adults at Johns Hopkins. My background is in pediatric hematology, and it's been my distinct pleasure to watch individuals with sickle cell disease grow around over the last 15 years. This week I had the amazing privilege of meeting a 77-year-old with hemoglobin access. My research has focused on fertility risks associated with sickle cell disease. In Brooklyn, we do know how to use a big voice, so I can do that. My research is focused on infertility risks, safety in performing fertility preservation in girls and women with sickle cell disease, and more recently is focused on the immense concerns I have about the morbidity and mortality associated with sickle cell disease pregnancy. And it's a total privilege to be with you tonight. Thanks for bringing us together, Tina.
Dr. Becker. Oh, yes, yeah, right. Ready? Whatever. So here's the thing. Okay, we know that we're still learning a lot about sickle cell disease, right? And there's some things that we really need to know more about. And is ovarian reserve, and sperm count, just in people with sickle cell disease at baseline. Can you talk a little bit about that?
Yeah. So I think the first thing is that we've acted a little bit like we don't know very much about this, but I think it's time to start acting like we know a little bit about this, because I think we do. It's just that the implications of what we know are complicated. So let's talk about what we know. For men with sickle cell disease, it's clear that the disease itself damages the testicles. It affects testosterone levels and it affects sperm levels. Most men probably with sickle cell disease have abnormal sperm counts at baseline. This becomes more complicated in the setting of hydroxyurea therapy, which is a profoundly beneficial treatment that we should be offering everybody for whom there is an indication and encouraging use. But it is clear that the drug is toxic to sperm, most likely, but we don't know, in a reversible manner. And so this creates immense clinical complexity when you're counseling patients who maybe were never told this before, because you may measure their sperm while they're on hydroxyurea and they don't have the sperm, and then hopefully their sperm comes back. That's mostly been my clinical experience. So that's some of what happens for men. The other profound infertility risk factor for men with this disease is that about a third of men with sickle cell disease experience a very devastating complication called priapism. Priapism is a painful and unwanted erection that can last for hours and is a risk factor for erectile dysfunction, and also terrible psychiatric comorbidity. As you might imagine, this is a very depressing thing to experience, and it's also associated with horrible repetitive nighttime awakenings for men who experience it, and then they have to come to the ED and experience the indignity of having your most private places poked, prodded, and examined over and over again. And the way that I conceptualize how bad priapism is from where I sit is that it's an indication for bone marrow transplant. So, and that's really how I think about what's a really bad complication of sickle cell. So those are some of I think those are the main two infertility risk factors I think about for men, and I guess you're asking about sperm counts and erectile dysfunction. For women, again, we didn't know a ton about this 7 years ago, but there have now been studies in historic samples in the United States, in the UK, in France, in Nigeria, all around the world, and they're all telling us the same thing, which is that women with hemoglobin SS disease, which is about 70% of people with sickle cell disease, have accelerated decline in their egg supply. And so all of these studies are telling us that same story. So I think we can believe it because it's from all around the world, and it's all telling us the same thing. The thing that's complicated about egg supply is that egg supply it doesn't always correlate with infertility. It's a risk for infertility, but it's not infertility. And at the moment, we really don't have a great answer for how hydroxyurea affects ovarian reserve. The best thing that we can say is that people for whom hydroxyurea is indicated are at risk of having lower egg supply than people for whom hydroxyurea is not indicated.
Okay, so thank you for that. You should begin to answer the second question at the same time. Okay, so I'm just going to expand on it just a little bit. Let's ask you, if I am talking to a 12-year-old who has been fighting to get on hydroxyurea and she will refuse, and she wants to know how is that going to affect her ability to have a child, what conversation should I have with her?
Well, I just wrote an 8-page paper about that after written training, so there's a few bullet points to get through, but
I've seen the paper.
I'm teasing you. I'm just saying it's 8 pages. So, in 3 bullet points, I think the first thing is that we know what untreated sickle cell disease looks like, and untreated sickle cell disease can only be understood as an infertility risk factor because you have to survive well into adulthood to reproduce. And so I think that's the first thing that we have to be really clear about. We know from not so long ago history what untreated sickle cell disease looks like, and it looks very hard for a 24-year-old trying to have a baby. So I think that's the first thing. The next thing is that fertility preservation opportunities exist, and we're working on making them accessible to everyone with sickle cell disease. But we have ways of monitoring egg supply, and we have ways of intervening with fertility preservation. And so if this is your central preoccupation as a 12-year-old, I don't think we need to act most likely right this minute, but it's something I can monitor for you over time, and I can monitor that whether or not you take hydroxyurea, and you'll be much better prepared for a safe and healthy pregnancy if your body's in the best shape possible by the time you're 20. The best way to get you there is with hydroxyurea.
So, I need the answer to the question. I wanted to hear it. I just want to say that you have a remarkable talent of expressing yourself. You really do. And I really appreciate the answer.
You knocked it out of the park. So I want to get a little bit personal because I don't know how many people know that before you were a co-founder of SC Red, you were my hematologist. And I think I was 28 when I came to you, and I had no idea, no offense, don't take it the wrong way, I didn't know that you were like this big champion for ovarian reserve, reproductive health, fertility, all of the things. And so I remember coming to you, and ever since my transplant, it had been in the back of my mind that I was probably infertile. But nobody had talked to me about it. And in fact, not even just the transplant and infertility, but just like reproductive health, period. You were my first conversation. And so I want you to tell us a little bit about what inspired you to get into an area that your peers were overlooking.
Yeah. My grandfather's best friend Sammy had a saying, which was always go where there's no traffic. It was one of his rules for driving. For me, this is a perfect fit of the concerns that I have for the world and the earth and for sickle cell disease. And I got really lucky that I had a mentor at Johns Hopkins who helped me find the questions that needed to be answered and to help me pursue the grants and patient population to care for who could help me refine my thinking and teach me so much. And so it's a little bit of luck and a little bit of pluck. And my mom's a big reproductive health advocate and my father's a physician, so the apple doesn't fall far from the tree. I want to say one other thing, because I think that for a long time we've talked about reproductive health care for people with sickle cell disease as if it's frivolous or beside the point or secondary to other things. And you and I have talked a lot about how it's integral to being a human being, and so it has to be integral to how we think about people caring for people with sickle cell disease. But I think that it's important to also acknowledge a really devastating reality particularly for adults with sickle cell disease in this country, which is that there are frankly not enough physicians to care for our patients. And so another thing that made it possible for me to pick this niche and really do research and not just devote my time to clinical care was that I had a partner in caring for 700 adults with sickle cell disease. So without a partner, and I wonder how that partner, so I'm feeling very sensitive to this at the moment, but without partners for people who want to do this work and who can care for the patients, we're going to be in a real pickle for advancing the field.
Yeah. Well, I want to thank you for taking this journey with us and for always prioritizing not just survival but quality of life. So, thank you. All right, Dr. Tisdale, you're up.
Okay.
A little bit personal again. When I had my bone marrow transplant, oh, I am. When I had my bone marrow transplant, actually, you're right. You go ahead.
Oh, so I introduced myself.
I'm going to introduce myself.
Okay. All right. So, who am I? Where do I come from? Yeah. So I'm John Tisdale. I'm originally from Charleston, South Carolina. I've been here for a long time. And I feel kind of like Barack Obama speaking after Michelle with the DNC. So I'll do my best. A couple of things that Lydia said actually echo with me, right? So I started my medical training in the 90s. And many patients coming in with sickle cell disease. And in that training, I was led to believe that these patients were coming in to get high. And it didn't make sense to me because these patients looked like they were really suffering with pain. And we had exactly 0 medications at that time. But we did have pain medicines. We had good pain medicines that could get rid of their pain, but I was always taught, as least you can, so the patients can get back out. That didn't really make much sense to me. And it was really brought home, and one particular patient who came in had a lot of pain, came in often, died. And it just, of course, didn't make any sense to me. How can a patient die from faking pain to get narcotics? So I found myself in the same situation as Lydia, where there was absolutely no traffic. No one seemed to be doing anything. It was as if the building was burning down, and no one was running for the exit. No one was doing anything. So it felt like something needed to be done. So actually for the last 30 years, it's been 30 years now, I've been working to develop ways to fix the disease, to cure the disease, first by bone marrow transplants and then by gene therapy. And I'm happy to say we finally have both of them working. They're still very hard to access. Unfortunately, that's another. That's why I can't do it right now. We're going to keep working, but so that's my story. That's how I got here.
That's a great story. So I was going to just mention that about, I don't know, 12 years ago when I had my transplant and got into trouble, I was at Hopkins, but my mom found you. And you really walked us through that. And we've been rocking together ever since. So I appreciate you for being here. And it's funny that you talked about December 8th already because I remember sitting in the cafeteria with you at NIH like 2 weeks before December 8th, and we were saying that we were both hearing rumors that those two gene therapies were going to be approved on the same day. And since you have been working on this for so long, can you share with us how do you feel? Like, how did you feel that day when you found out?
Yeah, so I mean, mostly I felt great, right? So we had been working on something for such a long time that turned out to be really difficult. You know, I used to say it's just because no one's working on it that we don't have a cure. It's the first disease that we need on a molecular basis. We had all these tools. We should be able to do this. You know, it's the same gene in every patient, so it should be simple. But it turned out it wasn't simple, and it took a lot of effort. And so I felt really good that patients can actually look to something now that's transformative, if not curative. We are a little reluctant to use that word, but it certainly looks like the other cures when you compare it to a bone marrow transplant from a family member. The results are the same. So I mean, it was amazing, but the price tag was just a shock. And for me, having worked on this all this time, to have it come out and cost so much was really quite difficult because here I am attached to this, inventing a lot of the stuff that went into it, and it's $2-3 million. So so it was bittersweet.
Yeah, thank you for that transparency. Dr. Troy, I'm going to come back to you. Because Dr. Troy is here and I have to get her on a flight. So why don't you start off by introducing yourself?
Thank you so much. It is such a pleasure to spend Friday night with all of you. I've befriended a number of people and also on stage. I'm Janet Troy. I'm an OBGYN and reproductive endocrinologist. And actually, prior to this panel, I was thinking about my internship in Columbia, in the United States. One of the very first patients that I had to take care of was somebody with sickle cell disease. Bad infection, mid-second trimester, and unfortunately passed away after this is an infection. And I too treated Mara, where it was basically his medical treatment was sickle cell crisis. He needs treatment, but what else do we do with it? And I ended up also doing further training in reproductive endocrine. And it was an exciting time because one of the very first, I know when we get to this jump to the punchline, that we were particularly excited about the potential of what IVF and genetic screening could offer was this kid said it's speaking in the Latin journals in 1999, just a fellowship at Cornell. And what was really remarkable was this couple had lost 2 pregnancies, terminated them, to be frank, because they were both affected by sickle cell disease. That's how they ended up diagnosed as a parent, that they were both sickle cell carriers. They went to Cornell, and that team was able to offer them in vitro fertilization, which is not an easy fertility treatment process. But over 2 cycles, they were able to help the couple find embryos and gene test the embryos and figure out which of the embryos actually didn't have sickle cell disease. And a couple of them ended up having twins, both of them sickle cell unaffected. And so that's actually the power, although it comes with still an expensive price tag, of how in vitro fertilization, assisted reproductive technology, along with gene screening, can help patients with sickle cell disease try to hope they're having a child who doesn't have the same tortured course in their life by trying to help screen our embryos and to find the embryos that have sickle cell disease or just have sickle cell trait. And I find that potential incredibly exciting. And during my career, I also found what medical was in faculty at Columbia. I helped co-run the Onco Fertility Program for fertility preservation. And what I found was cancer is not so dissimilar, actually, from sickle cell disease, and that we're giving this really awful diagnosis. And yet, we want to be told it's not just about surviving, it's about my quality of life, right? And again, I agree that the potential of having a family whether you want it now, in 5 years after you survive in 10 years, or maybe never alive, but just to know that it's out there, gives a person that sense of control and hope, but particularly in a medical crisis, is incredibly important. So I find that I'm feeling very fortunate I'm able to work with a company, Progeny. We're trying very hard to make sure as many patients get access to fertility preservation options to these expensive fertility treatments. And we still have a lot of work to do. But that's why I'm also excited to be talking tonight.
Thank you so much. So can you just talk to us a little bit more about what fertility preservation entails for both males and females?
Sure. So fertility preservation is a medical therapy, and it's a very and it's a tool for those individuals, whether they're basically healthy or have some medical condition or pending surgery that might injure or harm their fertility. And for males, it is relatively, not always, straightforward, but given the opportunity to freeze sperm. And for females, and this is where age is a big factor. I'm kind of smushing two answers into one answer. One of the biggest factors that affects female fertility is age. And that's because, unlike males in general, where I tell my patient it's like a light bulb goes off in the testicles in puberty, because I don't even tell them that, right? And they're making sperm every single day of their life, for the most part. With females, we're born with about 1 to 2 million preformed, pre-manufactured eggs and ovaries. We don't freshen up our supply. That's just natural biology. The egg supply, it just goes down with age. And with age also, because as eggs have been sitting there, the ovaries will be used over the decades of life, the quality and the potential to create a healthy pregnancy goes down. The issues are, in cases of patients with sickle cell disease, whether I'm on hydroxyurea, actually that's some of your people on the reserve, or not. For whatever reason, they're very reserved, as we already discussed before. The egg supply seems to disappear faster for women affected by this disease. So fertility preservation, if accessible, gives women the opportunity to potentially go through this process, again, not easy, where they have to align with a reproductive endocrinologist and a lab. They prescribe hormone injections they typically self-inject over the course of 10 to 14 days. Not easy. While they're juggling the rest of their life. They have to go through surgery in an office setting, typically under anesthesia. Again, risky as well. Small risk, but the risk is somewhat increased, right, in this population. And then while they're asleep, the surgeon actually tries to vacuum out the eggs from the ovaries. And there's a whole team of embryologists behind closed doors, looking at those eggs under a microscope, trying to figure out which of them are actually mature, feasible quality eggs. And unfortunately, sometimes you don't get them, especially when you're starting off with a low egg supply, although the opportunity is greater. If you offer it to somebody else with egg supply at a younger age, because quality beats out quantity in that case. And those eggs, they don't go into an ice cube tray. They go into liquid nitrogen tanks or vapor nitrogen tanks, and they can be stored for decades. And then at some future point, should one person want to come back and use them, whether it's for male frozen sperm or female frozen eggs, those gametes can then be thawed. and mix with the other gamete to create embryos through neutral fertilization, to give that person, to give that couple, if they're partnered, the opportunity to, using 5-year-old and egg strips and 5 years to try to add into their family. So that's fertility preservation.
Okay, fertility preservation 101, right? And level 2. I just have to say something here, because Tiana and I went back and forth about what are the questions, how we're going to answer, which one you ask. Yeah, no, I want to ask him, no, you know, okay, all of that, okay. And so one of the things that we decided on was not reading a bio and not introducing the person, having them introduce themselves. And I think that's the way all panels should be going forward, because the answers to the questions are brilliant, right? But beforehand, you all got to learn something personal about these people, that really connected you and made you even more interested in what they had to say. So I'm glad we decided to do it that way. I am going to ask, I'm going to make a comment. You have already answered the question, but I want to see if you have anything to add to my comment, okay? And my comment has to do with this. The way we want to eradicate sickle cell disease, of course, is with a cure, right? And we want people with sickle cell trait to know whether they're at risk of having a baby with sickle cell disease or not, right? But why do we want them to know that? Not because we're like, oh God, no, don't have that baby, because, that's, they're going to be sick if we're going to this and, all of that, okay? So I know some warriors that when they had a pain episode, they felt like maybe they wanted to die. But I don't know any that have decided that they didn't want to live. And so I think it's really important when we're talking about IVF and all that, when we talk about people finding out they're at risk for having a child with sickle cell disease, that we need to have a very kind of non-invasive, non-directive conversation with them about that. And since we were talking about fertility preservation, I thought that was something that is worth mentioning. So, do you have anything to really add to that? Because you answered the question. The question was how you see the world with fertility preservation, and I was going to preface it with this other stuff. So you already did it. What else do you do?
I appreciate that comment. I think it's actually incredibly important that each person who's on this planet is valued and, is a gift. Right? Unfortunately, some have to suffer more physically. And so I see, hopefully until it's completely eradicated through gene therapy and other methods and cured, that there are a multitude of available tools, and it's through medicine and through science. And we also need to not ignore a crucial part of educational awareness as well as the financial aspect. So people have as many tools available so they can try to decide how they want to proceed, should they want to grow their family.
As you both were speaking, I was thinking about how a paper that your father wrote has informed my thinking about this, and I thought it would might be my Good point. I wanted to say, maybe we can run this out afterwards or something, but, your father wrote an important commentary in the New England Journal in the 1970s. And it was at a time when we were debating sickle cell trait testing at the time, right? And whether we should be testing people for trait broadly or whether there should be targeted testing, and the consent process was about that. And your father outlined about 10 concerns with a program of universal trait testing. And what struck me when I read that from now with this lens of being a reproductive health person was so much, and I know this was from your mother as well, even though your father's the author, was so much about how those testing decisions pivoted on reproductive freedom and the abuses in this country of people of color, particularly Black people, and how this could be used coercively. Your father is extremely concerned, and his concern has been totally pointed out, that the hospitals that disproportionately served people with sickle cell disease in the Black community would not benefit financially from research or care for this community. We've seen that with the closure of different hospital systems. But I think the other thing he was very concerned about was making sure that this was never coercive. And I think, a number of years ago at one of the Cureside events, a mother of a woman with sickle cell disease said, you want to be careful when you talk about these technologies, because when you talk about IVF or PGT, you may be talking about people living lives without sickle cell, but for me, you're talking about a world without air, because you're talking about a world without my daughter. And so, I want to make sure that we know that we're not here to talk about a world without air. We're here to talk about a world where people have the choice to make the access to make the choices that are right for their family. And I didn't say much from reading that piece from your father about how to frame that, so I just wanted to make sure you to see that.
I have to take a point of privilege, and you all might have to eat your dinner real fast, because I don't know, this thing's really important to me. But you mentioned my dad, and then you kind of mentioned my mom, and I have to kind of mention my mom, who is now 95, and she allowed my father to dedicate his life to sickle cell disease while being a really good father and husband. But the thing I want to say is that my Aunt Sarah got pregnant when she was a teenager, and they sent her to the chicken coop. And the only reason she survived was because my grandmother took her food, right? And so my mother decided she wanted to do something about teen pregnancy, and contraception and education. And she spent 30 years as chair of the Board of Social Services in Michigan, appointed by the older Romney. And she was the force that changed the fact that babies of unwed mothers, illegitimate. She then removed that terminology, because they would say, Mrs. Whitten, our babies aren't illegitimate, and she had birth control and all of that. So I just had to say that.
Let me go off script a little bit too, and just give a shameless plug that her mother is on my advisory board.
Now, we want to let you go and get on an airplane.
One more question. I just want to ask you, you talked about access, and it's really clear that there is an inequity issue when it comes to oncology or to sickle cell, and what we have access to, and the lack of care, standardization, and access. And so I wonder if you could share with this community what we can do and how we can change that.
That's quite honestly. So there is major inequity, and it's to people who to speak out, and I think that to sort of deal with and it says but so that's something so that's something I think and the nice thing is that unfortunately, instance, mandating that information on not just the condition requires the certain therapy that until they start pushing and asking, and I have to so equal care for everybody with access. Report. Not asking
And this set off experience, particularly audience which other things. Have particularly coverage to try to
Well, thank you for speaking to that because I don't know how many people know that that's actually something that Dr. Pecker, myself, and Dr. Kinsey have been working on. I see that we'll be launching a discount program for the same with strong discount for individuals with sickle cell disease. And so definitely looking forward to making that a little bit more accessible. So,
the way to make enough and the cover, because I've seen them in the
I know.
so, yeah.
Thank you. Okay, let's go back to you, Dr. Sickle.
And add the stuff that you didn't already say because you and to the genetic cure, money and access and and talk a little bit about how big a role you think the whole issue of fertility plays.
This disease. So it's just about, and we're thinking, okay, we're gonna do this. The adults can make the decision for themselves. Important is so is family didn't get a transplant because their parents did productive decision for transplant was without. Unfortunately, what we is that for have the most frequent by the so so that I mean so we were the bone marrow transplant work since with curative therapies.
Yeah. So I just think a bone marrow transplant is the most difficult conversation I've ever had with every single family I've had it with. Because it's, but I'm so scared of sickle cell disease. I don't know which one I'm most scared of, So, and then, so parents are trying to, what, for your child, and your child might die. Really? 5%? If your child dies, that's 100%. Yeah, and I try to tell families that learn everything you can, make a decision that you think is the right decision, and that decision. And if it's wrong, it was not your fault because you did everything you could and you were doing what you thought was in your child's best interest. And I think parents,
this is that can't happen just once.
yeah.
Not about my judgment. So talk more. That's the conversation.
Yeah. Well, thank you both for speaking to that because did by sickle cell, and I was willing to risk anything, even death, to be cured, but I did not want to be infertile. And so, just thank you.
Because, you know, I'm the few over 1,000 transplants to individuals with sickle cell disease. And what's interesting, and that sounds really, cell disease is a disease that equal. So you're all nodding your head because you remember that. Populations, it doesn't look just like all country, men with sickle cell disease pursue with sickle cell disease. So our clinic population, but the representation of men compared to women. And so some of the complex reproductive choices regimen with a little more nuance around gender than I think that we might.
Well, the final question for you. Because there's hope, right? I know that you've also been in that on a way to do this. That's not constant about that.
It's really right, and that and so you'll work with them kill cancer. And it turns out the same kind of strategy can be 4 decades in cell disease. But we can make immune counter infection and those antibodies kill that infection. Most for antibody could keep people from dying if given simply cells and nothing else. And the way you go here and not like, and we've moved that all the way through the animal models, including, and it works. And then we put those animals um, housing outdoors, and they, 4 of the first 6 that we did that with had successful pregnancies. I mean, 2 animals got together. I think they knew each other from CU. We sent them off. They had a baby. So there is hope that we could do this kind of thing without chemotherapy. And ultimately, what we're is trying to do this in the bodies. These things that we can use to put genes into bone marrow cells that we have to take the bone marrow cells out to do. We're trying to do that same thing. You know, give an antibody, give that thing that we add a gene with, just in an IV, try to fix the disease. So that's, that's the whole grail. That's what we have to. That's, I think, still science fiction. It's starting to also show some promise. So I think we'll get there.
Unfortunately, and much to my dismay, I have to bring us to a close. But I think this conversation could go on forever, and everybody would stay just as engaged as they are now, because we had a fantastic panel. Now, what I'd like to do is that I would like to acknowledge all of the warriors in the room, and I would actually like for you to stand if you're a sickle cell warrior. Absolutely. I am so proud of each and every one of you. And this is why we're here. So thank you so much for being a part of this.
All right, guys, I think we have a couple of minutes for questions. Questions, comments?
I have a question.
Yes.
So I think that this incredible panel just has opened our minds to so many different ways where we can make a difference and we can help. All right, they're asking me to stand up. I don't need a mic. So they've given us direction about advocacy, policies, the benefits of research, the importance of early clinical care. And I think that one of the things that also brings us all together is to understand how we as a community need to move these issues forward. And so I'd like to ask the panel, what would be one of the most important things in order to bring to this situation? Can you tell us about what we need to do as a community to move this forward? Dr. Wayne Sharon, you want to start?
The moderators get a crack at it? Okay, so one of the things that I always say is implicit bias training is good. It is, it's good. Does it work? I don't know. I mean, are there white supremacists? Yes, there are. Are there doctors who are white supremacists? Yes, there are. Okay. And white supremacy is something that's taught. It's taught in the home, right? And if any of you saw 42, and he's out there, Robinson is out there, and he's getting ready to bed or whatever, and one of the fathers starts screaming the N-word, and there's a boy next to him who is like, "What is this? It's his son, really." And after a few minutes, he just starts doing it too because that's what his father was doing. And if we had been able to catch that little boy when he was first born and move him out of that household into a household where they weren't white supremacists, that's how we get rid of white supremacy. So I don't even know how to get rid of it. And I don't know about implicit bias training. Okay, one thing I do know is that
I care about how you treat a sickle cell warrior. I don't care about how you feel about them. You can hate them, you can think whatever you want to think, but you're going to have to treat them this way. And so it's legislation, and that's something we're working on in Michigan. That, you know, this is how you treat an individual with sickle cell disease. I don't care if you think they're a drug addict. I don't care whether you hate Black people, you think they're subhuman. You have to treat them like this. And I think that's the only answer.
Michelle. I mean, there's one thing that I think that we can also push for, and so it's education, right? So the one thing I really want to say is I think that we should continue to partner together to do research to move this. You know, so ALL in children had about a 10% cure rate in the 70s. It's 95% now. And that's because over those decades, patients went on clinical trials, almost all of them with ALL. And these were clinical trials where there were 8,000, 10,000 kids of each trial. And they used the same chemotherapy, just different doses, different schedules, different intensities. And they went from 10% to 95% cure rates. And we've got all these fantastic tools to try and make a cure. But we need to partner together to try and bring them to fruition. And so we have to do that together. We can't be researchers and subjects. We have to be participants together moving this field. So, I mean, you know, so to the extent that you can link up with researchers like these two have done, and like we've published together, then you know, I think that should be my message, right? Yeah. So yeah.
Jackie Robinson was my childhood hero. I revered him, and probably the only other heroes I've had are some of the people in this room. But he voted for Nixon. He did.
Did you really have to bring that up?
No, you know I did, because the question was about how we're going to change things, and I think we're living through possibly the most high-stakes moment for making sure that people with inequitable healthcare get access to healthcare that we've ever lived through. We say that every election cycle, but I think we really mean it this time. So, sorry to drag Jackie down like that, but you know, so I think the first thing is to really recognize the opportunity of this moment. And really recognize the power that this moment is bringing to our movement. That this is a moment for reproductive choice and freedom in the United States. This is a moment to elect a powerful, disciplined, and brilliant woman to the White House. And you know, we're going to need her, so that's really important. I think we shouldn't be shy about that with our community. So I think that's one thing we have to do. I think the other answer to your question, Dr. Whitley, is it depends on who you are, what you should do. You know, if you work in an institution, at Columbia, they've done this, where the clinicians have gone to the infertility center and they've said, you know, you offer these discounts to people with cancer, and we want you to offer those discounts to people with sickle cell disease, and they've done it. So if you work at an institution where you can bend the will of the institution to serve your community, then you should try to do that. If you have spare change in your pocketbook, then you should give it to Tiana. And so it just depends on who you are and where you're sitting right now. This is the universal answer is what we need to do this election cycle. And then I think a little bit depends on who you are and where you sit.
And so I agree with everything that's been said. I think education, myth dispelling, telling the truth and the reality of what some of the ramifications are, as well as what the options, so that a patient, an individual, along with their family members, can make their own choices. And also trying to educate the next generation of healthcare providers, the nurses, the doctors, who will deliver the appropriate high quality care, and also just making sure that this benefit is available to everybody who needs it on equal level. I think that's what I'd ideally like to see.
Dr. Lee for that. All right. Well, thank you. I want to thank Michaela. Amazing. I really could go on and on. So I think we'll be here again this time next year for part 2 of this conversation. But I want to actually talk about partnership. It's funny that you mentioned that because I think a lot of times in the sickle cell community, we've had to kind of operate in silos. And so I'm really glad that we're like in a new day where multiple stakeholders are at the table together. And with that being said, I'm really proud of my partnership with Bluebird Bio, who is one of the gene therapy companies. And so Tanya Prince is in the room, and I want to invite her to say a few words.
My glasses. Good evening, everyone. Good evening. Thank you, Tiana, for having me today. Dr. Sherman, I want you to feel better by saying to you that Robinson probably voted for Nixon because he knew that Nixon would support sickle cell. Yes, yeah. So I love history. So, thank you again for having me here to support you in your efforts. And I know that you probably would not have ever imagined um, your cause getting so much attention. And as a former CPO leader, I understand the challenges specifically that the sickle cell disease community faces. And for some of you here who may not know, I am also a mother and caregiver of a 33-year-old who lives with sickle cell. So the work that I do at Bluebird Bio is not just work for me, it is literally mission work. It is what I do every day. It is literally my why. I talk to my why every single day. A little over 2 years ago, Bluebird Bio um, Bluebird Bio reached out to the Office of the Inspector General in pursuit of an opinion, and we submitted a proposal so that we could be able to offer fertility preservation to support both eligible and government insured patients under our patient support program. One of the things that we really pride ourselves in is ensure that all individuals impacted and live with sickle cell disease have equitable access to services and supports to help them live a better life. Um, while we are and were disappointed after engaging with them about this issue for more than 2 years, the OIG decided, the OIG decided that the proposal that was submitted lacked data to conclude that fertility support would pose a sufficiently fraud and abuse under the federal anti-kickback statute to grant prospective immunity. With that being said, we anticipated a negative opinion, and that opinion confirmed our expectations around another approach. And what we're currently doing is continuing on with a legislative pathway in order to ensure access to fertility preservation. And I'm very proud of that because one of the things that I think we all understand in the sickle cell space is that you can't have one approach. You have to have a plan A, plan B, plan C. And so I'm really was intentional strategy and our approach and really working to make sure that this community has what it needs. One of the things that I love about industry at large and what I love about what I'm seeing is that partnership is not a tagline. And I really, really believe that um, it's right around the corner for sickle cell disease. I really believe that. And to talk to what you all were saying about how we make sure sickle cell disease community get what it needs. I tell everyone all the time to share your network. Industry, if you don't have dollars to support the CEOs, share your network, share your legal team, share your policy, share your governance team with these community-based organizations. Sometimes they don't know what to ask for, but you know what they need. Give it, and we'll succeed. So our commitment continues to, of course, remain with the sickle cell disease community. Um, we are stronger than ever. We continue to stand by you, stand with you, and continue to support you. And over the last year, we've been working directly with Tiana in ensuring that, her efforts are amplified and by sharing our network with her. So I just want to thank you for being receptive and being open and trusting us. And we just want to make sure that you continue to push the progress and the pendulum forward for sickle cell disease and just ensure that everyone who is impacted by sickle cell disease are able to. And I thank you.
So much for that, Tanya. While you're going back to your school, I'll get personal with you too, because I believe that you were one of my first calls when I was starting SG Red. And so it's been amazing to see how you've amplified the mission. All right. I'm gonna try not to get choked up when I do this. It was we talked about it earlier, how just the lack of access to fertility services has really been a challenge for me and is a large part of what inspired this organization. And so one of the first things that we did was partner with NMDP, formerly known as Be the Match, to launch these fertility preservation grants. And I think that in the last 2 years, there's been over 30 something grants awarded. And so it means the world to me. It means the world to me. And just talk a little bit about the impact of that grant.
Everyone. I would just like to say thank you for having us here to be a part of this event that's going on. It really means a lot to us. But first, I would like to start off by saying this is my beautiful daughter, Janaya Guilford. Um, okay, bear with me. This is my first time actually doing anything like this, actually sharing our story. So if I get emotional, just bear with me. I want to give pretty much a timeline of what led us here today. Um, I have 4 children. I have 2 boys and 2 girls. 2 of my daughters were born with sickle cell anemia. Janaya being the first. I have a young daughter named Jaleesa. If you would have told me 20 years ago that I would be standing here today, I wouldn't believe it. I wouldn't believe it at all. It's been a journey, just going through everything. I know many of you don't know that last year, Janaya had ABMT. We are actually just 1 year out from her having her procedure done. My son, Jacob, was her donor. My son, Jacob, was her donor. There's been a lot of obstacles along our journey leading up until today. We've always known that my son, Jacob, matched for Janaya. And we always had in the back of our mind that if her sickle cell was to progress, that we would have him in kind of hopes of it wouldn't get too bad, but he's there if she needed to have a transplant. Unbeknownst to us, we would have our fourth child, Jaleesa, who was also born with sickle cell. With us knowing that we had a match for Janaya, when it became of talks to actually going through with the bone marrow transplant, it was more so. It was more so. It was more so. I didn't want to proceed on with the bone marrow transplant with Janaya because I didn't want my youngest daughter to feel or grow up feeling that was it her sister that was actually cured, not her. There was a lot of things that kind of hindered us from moving forward with the procedure, but I would actually say what we thought were obstacles at the time were actually blessings in disguise. Let's see. I want to say, well, I'm just going to fast forward because I don't want to, take up too much of you guys' time. Once Jania's father and I decided we wanted to proceed on with the bone marrow transplant, it took a long time, a very long time, because I want to say 20, maybe 16 years ago, technology wasn't what it was at today. So when the procedure was first brought up to us, the risk outweighed the benefits, if that makes any sense. So again, we kind of put it off. Once we actually decided, I want to say maybe when Janaya was about 12 years old, once her teenage years, began to set in, and we actually kind of saw things progress when it came to her sickle cell. We decided that we would go ahead and go through with the procedure. But again, unbeknownst to us, Miss Thing here, she had it in her mind that she didn't want to do it. So after waiting all of those years and putting it off and just thinking things would get better once we actually made that decision. So Janaya said that she didn't want to do it. At that point, I kind of felt, not necessarily guilt, I kind of felt that maybe we should have done it earlier when she was younger. Because at 12 years old, I didn't believe that she was capable of making that decision on her own. Even though I commend her, I mean, that was a very strong, you know, statement and life altering decision for her to make at that time. I didn't feel as if she was capable of doing so. So me and her father were talking. I was like, you know, maybe we should have done it when she didn't have any say so. You know, maybe we should have just did it then. But again, we never thought of the overall picture of it. See, fast forward, here he is with Janaya in her senior year of high school. Um, oh, I'm sorry, I skipped the part. I do apologize. Um, the hospital that we were working with always told us that there was a time frame that we had to actually do the bone marrow transplant. They told us our cutoff point was around 15, 16 years old. So that's why when Janaya hit around the 12-year mark, things started to pick up. When she told us no, but you know, I kind of felt like, you know, it was a failure. I was a failure. That maybe we took too long. Why is it that we waited? What was the reason? You know, I had so many questions to where I felt doubt in the choices that I made. Once, see, after her senior year, and I guess
So fast forward, I'm actually done with my senior year and I'm getting ready for college. Um, as a freshman, you know, you think you're going to be able to do the same things everyone else is doing. And I don't know why I thought that because I've never really been able to do the same things everyone else is doing. I'm sure you know, but Georgia State is not really a campus feel. It's more of kind of like down here, it's like city, and you're walking a lot. And I didn't think that it would hinder me as much as it did. So that's when I decided to go ahead and do the BMT, even though I had put it off so long because I was simply just scared of being infertile. Like growing up, I've always been nurturing, which is kind of, I guess, what you would expect from the oldest daughter, the oldest sister. But I don't know, kids, I've always wanted to work with kids. I've always wanted to be a mother. So when I was doing my own research behind their back, just because I would hear them try to, you know, get to do it or talk about trying to get to do it. Once I saw the possibility of being infertile, I absolutely said no. And I said no up to until last year. I'm sorry. And so after I finally said yes, I said, but I just want to look into some other fertility preservations. We have to look into this before I go through. So while looking into these other preservations, we saw the cost, and that was just another obstacle. We didn't know how we were going to do that. That is when I believe her name was Christine. I worked with my team, my sickle cell team. I actually found you. Yeah. I'm so glad that I decided to be hard headed. I'm so glad. I would not be here, and I'll probably still be dealing with sickle cell because I'm strong on that note.
I just want to highlight. I just want to highlight that I'm so thankful that we didn't take that choice from her. Because even though we wanted her to no longer have to deal with these things, overall in the back of our mind, everybody just wants their child to, not have to worry about these things. Just, be a kid and be amongst your peers. If we would have decided to do the bone marrow transplant earlier in life, we wouldn't have gave Janaya, we would have taken that choice from her. So again, what I thought were obstacles in life were actually blessings in disguise. It was always so many reasons why we actually put it off, and put it off, and put it off. Before in the beginning, it was, technology isn't where it is. Let's just wait. Her sickle cell isn't bad enough. We have some time. Um, and fast forward, we had another daughter with sickle cell. Then it was okay. Well, I don't want to do the transplant now. Um, I don't want Jaleesa to feel any type of way. Let's just wait to see if she has, a match. Let's go into to be the match and actually see what goes on, because it would be perfect to have them both done at the same time. It was just always something that, again, just stopped us at that present time to actually move forward with it. Um, her at her teenage years, just being hard headed, but I commend her for actually standing up, because as a parent, children listening to parents, you do what your parents say. So it took a lot from her that showed me her character, who she was at an early age, to tell us, no, you can't. This is my life. I have a say in what it is that I want to do with myself. And I looked at her. I'm like, okay, again, I didn't know. I'm like, no, honey, this is what we're going to do. We thought about this longer than you have. You're just, kind of understanding what's going on. This is what we're going to do. I just am so thankful that we didn't go through with it, that we actually understood what it all entails. Because when you hear from the doctors, they say, okay, yes, you run a risk of infertility. That's all that they say. They don't give any information as to, well, this is what you can do. This is where you can go looking forward. Janaya brought up Christine, and if it wasn't for her, we wouldn't have gone through with it. Because Janaya, like Janaya said, when we was there, even though she had those obstacles in her way in dealing with school, she said, "Mom, this is important to me. This is what I want." The sickle cell team did, I want to say they did inform us to say, well, you can do fertility preservation. I looked into it. Once again, we saw the cost. It wasn't something that, I saw us being able to do. We wasn't, I'm going to be honest, we wasn't able to do it. We wasn't able to do it. And I really feel as if Miss Christine didn't make it an option for us, Janaya wouldn't be cured from her sickle cell. We would have, I don't know how it would feel as a parent. I don't know how it would feel as a parent. I do. And yes, I want to tell you that I want to say that even though I'm your mother, I look to you as the, I don't want to say epitome, but I just look to you because you're so strong, and I'm blessed to feel like I actually did something very
All right. Thank you. And Janai, I know that you and I have talked, and I know that you are worried about how you're going to be able to go through IVF later. So I just want to make this promise to you that the same way these fertility grants came to fruition, I will make sure that we get grant money so that you can afford that IVF. I think anybody who knows me knows that this woman means everything to me, and I am just so honored to have had her a part of this journey. And so, all I can do is let you close this out.
I know that it's been a long evening, but I just want to make sure that people who need to leave, please feel comfortable exiting, because I do want to take a moment to talk about time and opportunity. And one of the things that is very prominent in communities of color is really respect for elders and elder saints. And DC is home for me. I grew up here, raised by my grandmother and my mother. And my grandmother always had a saying for everything. And one of her favorite sayings was, "No time for foolishness." And it started with being her love language, because my grandfather, who was an incredible advocate here in DC, would go off and protest all the time. And when he would leave, he would say to her, "Give me a kiss, because you may not see me again." She was very proper and very stern. And she would look at him and she'd say, "I'm not kissing you. I don't have any time for foolishness." No time for foolishness. And as I got older, right, that no time for foolishness became a little bit of a different message. And if I brought home a young man who she didn't approve of, it became shortened. And when I would be leaving the house, it would be like, "No time." Like, no time. Like, don't even spend any time there. And then as my mother and I got into a lot of things around DC that let me know what I was going to be passionate about. George Washington for medical school brought me to DC Children's, right across town, where I had the privilege of being educated by a nurse practitioner who took care of over 600 children living with sickle cell. And as a medical student, right, I learned even then in one of the most prestigious hospitals in the country that there wasn't a doctor who was dedicated to sickle cell care. And that inspired me to really take on the challenges of what was so often an overlooked community. First individual described in 1910, all along we could diagnose babies and then with penicillin do something different. And it took an act from Nixon to get that vote in to do newborn screening. It was his motivation, but it worked for us. And we got newborn screening. We got by any means necessary, newborn screening for sickle cell. And so then we had the capability of diagnosing individuals early in life, starting life-saving antibiotics, just an antibiotic twice a day. And that's what went from when I went to Children's Hospital of Philadelphia, because My issue was, how in the world could we have so many therapies to do so much for so many different conditions? And the first individual with sickle cell described in 1910, it wasn't until 1995 where we had a medication that could do something differently. So that no time for foolishness became a call to action in my family. And my mother would say to me, you spend every second you can in that hospital doing what you need to do because we don't have any time for foolishness. We need options. We need opportunities. We need to look at our young people who are advocating for things better and say, we see you. And Tiana, we see you. You could have done so many different things with your time and your opportunities. And you decided you didn't have any time for foolishness. And I am so proud of you for the decisions that you have made along the way. And we talk about the Witten family all the time because they come full circle. I can still remember Dr. Witten seeing me at the first SCDAA convention and schooling me on everything from sickle cell trait to sickle cell disease and back again. And I just remember we should really think about the words of our elders. And I'm standing here saying to you that I know my mom, my grandmom would see that same thing in you that they saw in me. And they would say, you go, you say something, and you do something, and you make sure that foolishness has no time. We have the opportunity to make sure that this organization has the resources they need to move forward. My checkbook is open, and you know that, right? But we know that there's more, and I'm going to ask for money too, but there's more that we can do to make connections. Everybody who leaves here today knows somebody who can make a difference. So when you leave here, I want you to bring this message forward about how just incredible SC Red is and how they are fighting for reproductive rights and the opportunity for fertility preservation for all individuals living with sickle cell disease when and if they need it. And that should be the connection for whatever pharmaceutical company, for whatever federal agency, for whatever healthcare system, for whatever community-based organization, that you bring this message so that this organization gets the resources they need to move forward. I'm ending, I promise. And I will end with two messages. The first message is I think about the fact we used to celebrate every time we had a graduate from high school in sickle cell clinic in the 90s. And now we would be broke if we were celebrating every graduation from high school, right? And part of the message is seeing you and your future together and supporting you in this journey. And there's a famous saying by don't count every day, make every day count. And I know I see that in you. And the second message is also, if your mind can conceive it and your heart can believe it, then you can achieve it. And those two quotes are from my No Time for Foolishness grandmother's favorite athlete, Muhammad Ali. So before you leave tonight, make sure Tiana has your contact information. Please pass on the word about this fabulous organization. Speak forward about sickle cell disease, not only in September for Sickle Cell Month, not only Juneteenth for World Sickle Cell Day, but all the other 363 days out of the year. Thank you. Thank you so much for your time this evening.
Listen, when Kim Smith Whitley is standing in front of a room and giving you a tribute, I think we can all agree that you made it. So thank you. That really meant the world to me. I'm really glad it was recorded. Probably watch it every day. But again, I just wanted to thank you guys so much for spending this evening with us. And can we just give a round of applause for my co-moderators?